So basically, what we are doing in this paper is we are trying to assess the impact on one specific health outcome, which is mortality, of a reform that was introduced in Spain in 2012 that restricted access to the healthcare system for a specific part of the population, which is undocumented migrants. Okay? And so we're going to use this reform to see what's the impact on one extreme outcome, which is mortality for the population that was affected by this reform, which are undocumented migrants. So I'll give you more details about the reform. But before I start telling you about the reform, let me tell you a bit about migration and why is this important. So we all know that international migration flows have increased during the last decades. But just a few numbers. So in 1990, there were 152 million migrants in the world, and this has increased by 60% from 1990 to 2015. So most of these migrants migrate because they are looking for better opportunities, economic opportunities, and so 60% of those have been settled in developed countries, and they represent around 11% of the total population in these developed countries, and then 40% have settled in developing countries, although they only represent less than 2% of the population in developing countries. So it's difficult to get estimates, but a significant proportion of those migrants are undocumented. So I'm giving you two different estimations. So one is from the International Organization for Migration, and they estimate that around 10–15% of those migrants are undocumented. And if we look at data from the UN, they even estimate a higher proportion of undocumented migrants as a proportion of all those migrants. So they estimate that around 1/4 of the migrant population is undocumented in the world. So the US, as you may guess, the US is the country with the highest proportion of undocumented, and there are 11 million of undocumented migrants, and these represent 26% of the immigrant population in the US, and around 3.5% of the total population in the US. So this is a significant proportion, both of the immigrant population and also of the total population. So if we look at the EU, for example, EU 27, there's a lower proportion of undocumented migrants. In particular, they represent around 10% of the immigrant population and less than 1% of the total population in the EU. These numbers are much higher if we focus only on southern and eastern Mediterranean countries. And some estimates suggest that around 64% of the immigrant population in these countries are undocumented. Okay? So if we look at Spain, which is the country that I'm going to be talking about, what we know is that the evolution of the undocumented migrant population has followed relatively closely the business cycle fluctuations. So for example, in 2002, 15 undocumented migrants represented 15% of all migrants, or all immigrants in Spain, and that was less than 1% of the total population in Spain. But then, because of the economic boom, these numbers increased in 2005 to 36% of the immigrant population and around a bit less than 3% of the total population. So this is, in 2005, these numbers were relatively similar to the US. Yeah? So these estimates refer to the number of undocumented migrants that are in Spain in that year. No, so data, even this data is really extremely difficult to get. This is a very obscure wall. So I'm trying to get more recent data, but it's proving to be complicated. Yes, who are in Spain in that year. It's not? No. This is a particular year. So this is, usually these estimates are based on census data.
would be unlikely that they would do just the opposite.
Yeah. 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 And then from 2005, there's been a gradual reduction, again, coinciding with the economic recession. So all these migration flows and this increase in migration flows has put the immigration debate at the forefront of the political arena. So for example, the UN issued a resolution in 2013 which advised countries to promote universal access to the healthcare system for all immigrants in their countries. But we all know, and some of you have worked on immigration, that the native population have some concerns, or that there's some concerns in receiving countries about the impact of immigrants on the native population, in particular employment, wages, and also public expenditures. And so at the end of the day, many countries restrict the access for all immigrants, but also especially for undocumented immigrants, to public services. And so because I'm gonna focus on healthcare, now I'm gonna tell you a bit what's the regulation in some of these countries with respect to the access to the healthcare system for the undocumented migrant population. So for example, in the US, which we've seen is the highest, the country with the highest proportion of undocumented migrants, those undocumented migrants are not eligible for either Medicare or Medicaid, which are the two biggest public health programs in the US. So they do not have access. Apart from that, there was also, you may know, I mean, most of you know, there was also an expansion led by the Obama administration in 2014, which was the Affordable Care Act, which expanded coverage to certain parts of the population, but this was only for the native population again. So undocumented migrants were also left out of the expansions in the Affordable Care Act under the Obama administration. So this is the case for the US. Now, in Europe, the situation is a bit better depending on the country. So in the EU 27, for example, in 5 countries, the undocumented migrants have the same access to the healthcare system than the native population. And Spain was one of those countries until 2012, when the reform kicked in. In 12 countries, they only receive emergency care. And in 10 countries, even emergency care is restricted for the undocumented population. Okay? So this is a bit the overall picture. And so in this paper, what we'll try to do is to analyze the impact of a reform that restricted access for the undocumented migrants to the healthcare system on mortality of this population. And we'll exploit a reform that was introduced in 2012. I mean, as I will tell you, what we find is that indeed mortality increased for this population, and because we have information on the cause of the death, I'm going to be showing you that which specific causes of death increased, and I'm going to be claiming that these are the causes that are more easily avoidable when you get access to the healthcare system, when you do have access to the healthcare system. Okay? What is called in the literature as amenable causes of death, which are those deaths that can be prevented if you get more easily prevented if you get access to the healthcare system. So what's been done in the literature? So most of the literature has focused on the impact. So I'm going to only be focusing on mortality as an outcome, because there's a lot of other literature looking at other health outcomes, but because I'm going to be focusing on mortality, I'm just going to tell you the literature on mortality. So there's been quite a huge literature analyzing the impact on mortality of expansions of the healthcare system, mainly based on the reforms introduced by the Obamacare administration in the US. And so this, as I said, these papers, because Obamacare was only targeting some parts of the native population, these papers are also analyzing the impact on mortality of these subgroups of the native population. So most of the papers find strong reductions in mortality from getting access to the healthcare system, And one of the latest papers by Summers at Harvard finds a reduction by 6% in mortality. And also some papers find no impact of expansions in healthcare coverage. Now, it has been claimed that the differences between finding impacts or not are due to the different focus on the subgroups of the native population that each of these reforms targets. So for example, some of these expansions target children, some of them pregnant women, some of them the poor, and some of them the elderly population, okay? And so that's why some papers find impact, strong impact, some papers find no impact. But all of these papers are focused on subgroups of the native population. And so there is no impact on analyzing the impact of healthcare, access to healthcare for undocumented migrants. And why the impact may be different? Well, because we know that immigrants are different in some sense, in some dimensions, than the native population. In particular, we know that undocumented migrants are younger and they are healthier when they arrive in the country. So this is the healthy immigrant effect that has been documented. And they also have less healthcare utilization, okay? And so the conclusions of these papers analyzing healthcare access, expansions of healthcare access, may be not extrapolated to the undocumented migrant population. So the way we see the research now, we think that we can contribute in 2 dimensions to the literature. The first one is that we think it's the first paper that looks at the impact of healthcare on mortality for undocumented migrants. And we believe that this will have important policy implications given the current increase in migration flows and the expected increase in future years. And the second contribution is that it's the first paper that looks at restricting access to the healthcare system instead of expanding access to the healthcare system. And so we're going to look at a particular specific group of the population, as I said, undocumented immigrants, but we think that this could be important to be extended to other parts of the population, given the current discussions, especially in the US, about restricting access and dismantling the Obamacare expansions. Okay? Okay, so let me tell you a bit about how is the system and what did the reform introduced. So this is the system as it was before the reform. So before 2012, the Spanish national health system provided free access to both primary care, specialized care, and emergency care for everybody. Okay, this system is funded with general taxation. And then since 2002, there's been a process of decentralization to the autonomous communities, which are the biggest regional units in Spain. And so these regional units are now in charge of managing and providing healthcare, while the central government is in charge of designing and implementing national legislation and in charge of the coordination of the entire system. So before the reform, before 2012, coverage was universal. So undocumented migrants were entitled to the same type of access, free access to the same services in the entire healthcare system than the native population. And so the way it works is that it used to work before 2012 is that you only needed to be registered as a resident in a municipality to get access to the services. And the way you used to do it is you'd go to the municipal office and get registered, and for that you only needed some kind of ID and a proof that you were living in one of the houses. And then that granted you access not only to the healthcare system, but also, for example, to the educational system. So if you had children, your children could also be registered in one of the public schools, even if they were undocumented. Okay, so this was a relatively simple process, and your risk of being reported as undocumented was very low, and the incentives for doing that were quite strong because you could get access both to the educational system and to the public healthcare system for free. And so the way it works is that you get a healthcare card at home, and then once you go to the hospital or to the GP, you only have to show your healthcare card.
So the way you buy your healthcare card, so an electricity bill would suffice?
Yeah, yeah. Because that would suffice to be registered, and then you get access to the healthcare card. Okay, so then in 2012, the right-wing party introduced this reform in the healthcare system. The aim of the reform was to save resources and to dissuade health tourism. And the content of the reform was that access was restricted to the healthcare system for undocumented migrants, for those that did not have a residence permit. And so the way it was implemented is that undocumented migrants, the healthcare cards of undocumented migrants were canceled by the government. Okay? So there were 3 exceptions to this new legislation. So even if you were an undocumented migrant, you could still get access for free in these 3 exceptional cases. In case of emergency care for serious illness or accident, in the case of healthcare during pregnancy, birth, and postpartum, and in the case of children under the age of 18 years old. Okay? So it's been a bit difficult to get numbers on how big was this reform and how many people were affected, because the government was kind of, did not like to provide these numbers. So, but the opposition party kind of pressured the government a lot. And then in a speech in the parliament, in the Spanish parliament, they provided those numbers. So the government reports that almost a bit less than 1 million healthcare cards were canceled. Okay, so this is the numbers that we have. This represents, at the time of the reform, this represents 14% of the immigrant population and a bit less than 2% of the total population in Spain. Right? So these are big numbers, and I'm showing you these big numbers to try to convince you that I'm going to find mortality impacts, because this is a lot of people. And of course, there's been, I mean, you can imagine, and those of you who live in Spain, you probably read that in the newspapers. That's been a high concern by NGOs on the impact that this will have on the health of these individuals. And so there's anecdotal evidence in the newspaper or in some of the reports that these NGOs released of an increase in tuberculosis in the immigrant population, or an increase in HIV infections, which was also reported for the case of CRES, for example, or mental health problems. And so there's an article in The Lancet providing some anecdotal evidence of these potential health impacts for the affected population. But there's been no study analyzing the causality of this. Yeah. So there was, so the reform introduced kind of co-payment for certain types of drugs, but this would also affect that was for the elderly, yeah, for pensioners. But I'm going to be excluding this, the elderly.
So there was no, as in the card of people having been contributing to the social security system for a while?
So no, there was, so most of the native population was covered, because you either, so there's, it's a bit more complicated than I'm putting it here, but you either had to be working or being the dependent of somebody who was working or receiving some kind of a social assistance benefit. So at the end of the day, most of the native population was covered. The majority of the native population was covered. So I'm not a theorist, and I want to go very quickly through this slide, but apparently from a theoretical point of view, the impact is not that clear, because if you look at the papers that look at expansion of healthcare coverage, you have these two different potential impacts. One of them is that, of course, if you increase access to the healthcare system, you increase utilization, and then health would improve. But then on the other side, there's also some papers that find that when you get access to the healthcare system, you also get induced in more risky behaviors, and so your health potentially can be affected also, negatively affected by that. So in principle, the impact is not that clear. Okay, so which data are we using? So we are using data from the death registers. So we have everybody that died in Spain from 2009 to 2015. So this is population data, all deaths. And then we also have data on population. And so what we're going to do is we're going to compute mortality rates, so the number of people that died for each group as a percentage of the population in each group, for each region, so autonomous community, and for each time. And the time dimension is going to be month. And then I'm going to be doing that for the native, which I'm going to use in this first version of the paper. I'm going to be using as a control the native population, and then the undocumented migrants, which I'm going to define in a second, which is going to be my treatment group. So I'm also going to be restricting to only those that are younger than 65, because the age distribution is very different from natives and undocumented, and because of all these other changes in the native population in terms of reimbursement of drugs. So I'm going to be excluding those older than 65. And so how am I going to define undocumented migrants? So of course, in the death registers, I don't know if somebody is documented or undocumented. So I'm going to be following the literature in the US, which defines or assigns undocumented status depending on the proportion of undocumented that are living in the country for each nationality, right? So, for example, in the US, the way that these papers, the literature on undocumented migrants in the US deal with this issue is they assign as undocumented all migrants from Mexico. So they are kind of estimating a lower bound, because of course some of these migrants are not undocumented, but it's very difficult to get individual information on the legal status of the person. So this is a table that I'm taking from an European project that was implemented in 2009, and they calculated the percentage of undocumented migrants in several European countries. And so this table is for Spain, and it corresponds to 2009. And what they do is they calculate the percentage of immigrants that are undocumented for each of those nationalities in Spain in 2008. Okay? So they get data for each nationality. They get data on the number of people in the census, and then they subtract the number of residence permits at that time for each nationality. And so this is the number of irregulars in the country, and then they calculate the percentage of irregulars for each nationality. Okay? So so I'm now trying to get better data on the percentage of undocumented, and I'm trying to construct this table myself, but it's not that easy, because census data is very much available, but the number of residence permits is not, or I'm finding some difficulties in finding this information. But as I said, this is work in progress, so I'm trying to get better data on this table, the percentage of irregulars, but for now, this is what we get. I mean, yeah.
So basically here, the identification relies on the proportion of immigrants increases. If you basically observe that in those areas there is like a bigger mortality, then you're basically attributing that.
No.
No?
No, I'm going to be doing a difference in difference. So I'm going to be comparing mortality rates for those that I'm going to be labeling as undocumented against the native population before and after the reform.
This attribution to the mortality to the immigrants, to see how you can do that, and what are the big assumptions you're doing that?
Okay, so let me solve first the treatment status, and I'm going to be coming to the identification in a second. So, I mean, yeah, I shouldn't say that, but for example, there are a couple of things that I don't like from this table. Like, for instance, apparently there's no irregular migration from Morocco or from China, right? And if you live in Spain, this is maybe not that correct. But for now, this is what I get. And so I'm going to be using that, and I'm going to be doing two strategies. The first strategy, which is what I'm going to be doing throughout the presentation, is because most of the irregulars come from three areas, regional areas in the world, so Central and South America, Africa, and Asia. My first approach is that I'm going to be labeling as undocumented migrants everybody that has a nationality from one of these three regions. So Africans, Central and South Americans, and Asians, in my first specification, those are going to be undocumented migrants. So I'm estimating a lower bound, but then I'm going to try to become more specific, and I'm going to be labeling only as undocumented migrants from these nationalities that rank at the top of this list.
So the census data is from the same year as the...
Yeah. Yeah. So let me show you some descriptive evidence. All the yeah. Yeah. I completely agree. So that's why I'm trying to get more data on that, and that's why in my first approach, what I'm going to do is to label everybody from those kind of nationalities or from those regions as undocumented. So in the worst case scenario, I'm estimating a lower bound. Sorry? Well, that's the thing, that there is no official reports on that. You have to construct. So I get it. This is from an European project. So it comes from the census, and from the Ministry of Interior Affairs, the number of residence permits. Yeah, it's Enrique González, who was the one who was participating in this European project and constructed this table by looking at data on the census from the National Institute of Statistics, and then the number of residence permits from the Ministry of Interior Affairs.
Yeah, and I understand why you showed so much detail. Like at the end, you just wrote that over from
Well, I am going.
You don't need to take this so seriously.
No, I'm going to show you one regression with that today also. So the approach is to be more, to get a better target of the irregular immigrants. And so I have one additional regression from the last presentation you saw a week ago. No. I mean, well, for now not, but that's the approach I'm going to follow, or I try to follow. It's the region. So those are from Central and South America, and those are from Asia, and from Africa.
They have double nationalities, Spanish and another one?
No, this is counting only those that
have one?
Yeah. So let me show you some descriptive evidence. So I'm going to show you mortality rates by each of these three regions, and this is going to be yearly data, but in the regressions I'm going to be using monthly data. Okay, I'm just showing yearly data because there's a lot of seasonality. So this is for all groups. So this is mortality rate for the native population. This is the number of deaths per 100,000 individuals. And this is undocumented migrants, number of deaths per 100,000 individuals. Here undocumented are those with a nationality from Central and South America, Africa, and Asia. And you can see that, so this is the time of the reform, September 2012. you see a decreasing trend for both groups. And then from the time that the reform was implemented, you see that for undocumented migrants, there's an increase in mortality rates. And you can see that so this is for each of the specific regions. So this is for Africans, again, strong increase in mortality rate. Central and South Americans, again, decreasing trend and then an increase after the reform. Every year, yeah. Number of people that die every year divided by the number. Yes, yeah. My definition of undocumented.
So this is based on that attribution that.
Yes, yes, yes.
So how is it possible that then, after 2003, because you're just using the number of migrants,
I'm dividing it by the population of each nationality living in Spain at each time, because I'm using nationality.
The trends in undocumented migration change over time, particularly due to this reform. My feeling is that two undocumented immigrants, you're having them in your numerator, but not in your denominator, because you don't observe.
Sure, I'm going to be talking about migration in a second. Give me 10 minutes.
So would it be fair to say that what you're labeling undocumented includes documented?
Yes, yes. It's potentially undocumented, considering that those are the ones that have a higher probability of being, the nationalities that have a higher probability of being undocumented, yeah. So it's a lower bound, yeah. Okay, so my first approach is very simple. So I have a dummy for being undocumented or not at each time and for each region. It's one for after the reform. Again, this is monthly data. Now I'm going to be using monthly data. So I include year and month of the year fixed effects and region fixed effects, unemployment rate at the regional level at each period of time, and then some of the specifications I'm going to be showing you with and without controls. When I include controls, those are the percentage of people working in the service sector, the percentage of people with college education for both undocumented and the native population. And the standard errors are clustered at the regional level with wild bootstrap because I have 17 regions, because I'm excluding Ceuta and Melilla. So age is not there, but I'm going to be showing you different regressions for age groups. So this is the results without controls. So this is for everybody. This is only for Africans compared to the native. This is only Central and South Americans compared to the native, and this is only Asians compared to the native population. And we see strong increases in mortality. For the three groups, this is the mean of the dependent variable before the reform. So this is the impact of the reform with respect to the mean. It looks like a big number, but mortality rates for the undocumented are very low. So this corresponds to an additional 70 deaths per year. So it's not such a big number. So this is without controls, only with the fixed effects. Now, when we include controls, everything stays the same and still very significant. And in the last specification, I also include controls and region-specific linear trends, and we still get similar impacts again. And this corresponds to 70 additional deaths per year.
How do we give one number, like say the Africans, 0.78? How do we do that?
This is an increase by 0.78 in the mortality rate, which is 4.72. The baseline mortality rate, which is 4.72. So this corresponds to an increase of around 16% in mortality rates.
With respect to the natives, or with respect
No, with respect to the, yeah, before the reform. Yeah.
How can we know that the composition of migrants is changing?
Yeah, so this is monthly data, but I'm going to be showing you data on the composition also in a second. This is monthly data again, so it would have to be that there's an immediate impact on, but completely agree, I'm going to be showing you data on migration. Yeah, yeah. Yes, yes, so I'm going to be showing you data on that, yeah.
Sorry to go back to this. So just to be sure I understand the dependent variable here, this is the adjusted or the unadjusted mortality rate, in the sense that have you already done the attribution to immigrants?
No, unadjusted.
Yeah, okay, so in that sense, then you don't need that attribution, because what you're doing is you just have for a region the mortality rate, and then you are checking whether when the immigration goes up, interacted with the policy reforms, whether that led to an increase in the mortality rate.
So this is the number of people that die divided by the population of this nationality. So the problem is that there could be, yeah, this is adjusting by the number of people that changes, but it could be these people that leave and come could be selected on health, and that's the concern. So if we look at results by age, we find stronger impacts for this group, but because mortality rates are bigger for the elderly, not elderly, middle age, sorry. Early middle ages. At the end, it represents an increase by 12% for those groups. Now, we also find, I mean, small, but we also find significant impacts in the group that was apparently excluded from the reform, which is the children. Now, we have to do more on that, but I'm not that extremely surprised because there's some literature in the US talking about the chilling effects, which, for example, report that, for example, undocumented migrants living in the US who have children in the US, and those children are native because they were born in the US. There's a lot of literature showing that these children are much less likely to go to the doctor, even if they are native, than the native population, because the parents are kind of afraid of being irregular and then of being deported. So we have to do more on that, but this is at least consistent with this evidence in the US of the existing of chilling effects. I mean, it is after the reform. So because this group is excluded from the reform, so they should get access to the healthcare system, but their parents are excluded.
Those age 40 to 64 were affected by the reform?
Sure. Sure.
So you had immigrants at age 45 arriving to Spain?
No, not arriving. They could be living here, and then their healthcare card would be cancelled. So this is the new regression, Libertad for you. So this is the other way of attributing immigrant status. So here, immigrant is one for those that rank at the top of that table. So for those, I think it's 18 nationalities with a higher probability of being immigrants. And 0 is for the native and the rest of immigrants. And so again, I still find a strong impact in mortality. Okay, so let me show you that there is a parallel trend before the reform. So this is event studies type of regression. So here I include the dummy for each year before the reform and after the reform, and then the interaction of these yearly dummies with the treatment status, with the undocumented status. And so we see that 2 years before the reform, there's no change, there's no differences in mortality rates between immigrants and native, undocumented migrants and native. 1 year before the reform, there's no change. And then in the same year that the reform is introduced, there's a strong increase in the mortality for undocumented. And then this is still there 1 year after and 2 years after the reform. And so this is, I think, kind of convincing because there's really strong parallel trends before the reform. And so this is the same thing, but just plotting the coefficients. Okay, so I'm now trying to see what are the channels or what are the potential mechanisms. It's difficult, but so one of the things that we can exploit is in the mortality records, we know the cause of the death. And so what we've done is we've grouped the sources of death into 21 groups. And I'm going to be doing a regression, the same regression for each of the causes, sources of death, and so that we can see which is the mortality that is increasing for this group of individuals. So the first one is infection disease, cancer, blood disease, endocrine, mental, nervous. And so what I find is very strong increases in cancer deaths, very strong increase, well, relatively strong increases in mental health problem deaths, and then strong increases in circulatory and respiratory deaths. I think one good placebo is that for external causes, which are accidents, not only the coefficient is not significant, but is very precisely estimated at 0. So, then I looked a bit at the literature, and there's some papers dividing these sources of death into more or less amenable sources of causes of death. Yeah.
I mean, in those regressions, there is one thing that is quite systematic, which is the undocumented immigrants. It's always negative.
Yeah.
That they have actually lower mortality.
Yes, but that we saw also in the graph. This is consistent with the healthy immigrant effect.
Okay.
Yeah. So I'm grouping these sources of death into amenable and more amenable and less amenable sources of death. So amenable mortality is defined as death from causes that should not occur in the presence of timely and effective interventions, healthcare interventions. So these are the sources of death that can be prevented if you get quick access and effective access to the healthcare system, which is precisely what the reform does. No? The reform prevents those individuals to get timely and effective access to the healthcare system. So this is used as a measure of performance for the healthcare system. So I'm going to be using, I'm going to be grouping these sources of death into more amenable and less amenable. And the idea is that those sources of death that should be more affected are those that are more amenable. Because if timely intervention is more determinant in your death, then those are the sources that should increase. And so this is more for more amenable deaths. And what we see is there's a strong increases in this. And so the coefficients, so the impact is around 30%. And when we look at less amenable sources of death, we still find an impact, but it's much smaller. And in some cases, it's not significant. So let's move to migration, because it's potentially a very strong problem. And so this, yeah.
Before you do,
yeah.
It might be worthwhile picking up on one of Luigi's suggestions on the mortality rates. Could you not risk adjust the mortality rates for the indigenous population somehow, so that you clean out their mortality? Because as I understand it, you've got total mortality, you're dividing by what you call undocumented immigrants.
So I have the mortality of undocumented immigrants, and I'm dividing it by the undocumented population. And then I have native population deaths, and I'm dividing it by the population of natives.
So how did you get the undocumented mortality?
Well, in the register, death register, I know the nationality, and so I'm assigning undocumented. Okay, so migration. So this is the population trends. So this is my denominator. So here is the evolution. This is millions of people. This is, sorry, there's no label, I just realized. This is for the native, and this is for the undocumented migrants. So this is the number of people, native population. So this is numbers of native population, and this is the numbers of undocumented. So this line is the real value. So you see that there is indeed a kind of response to the reform in terms of migration. So there seems to be, like some months after the reform, there seems to be people, undocumented immigrants, leaving the country, which makes sense. Now, the problem is whether those are selected in health or not. So if those leaving are those in worse health, then I'm fine because I'm estimating a lower one. But the problem is if those that are leaving are those in best health, because then those that stay have a higher probability of dying, and that's why I find increases, right? No, this is population data. So this is not migration data, this is population data. So the population of undocumented decreases after the reform. This is my denominator. I looked at data on migration, but it's kind of difficult from the National Institute of Statistics. They have population data by nationality. Right, but yeah. Yeah. So, yeah. So, yeah, 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 I agree. So this is based on census data, and there's information every 6 months on the population. Yeah, yeah. So, okay, so there's a decrease in the population, so I'm gonna be dealing with that in 2 ways. The first thing that I'm gonna be doing is I'm gonna be kind of estimating a population which does not decrease. So this is this trend. So I'm gonna be estimating the population as if there was no change due to the reform, and I'm gonna be dividing my mortality rates by this number. Of course, this could also still be selected. And so the second thing that I'm gonna be doing is I'm gonna be looking at whether there is change in population in each of these subgroups. And then if I find some subgroup for which population doesn't change, and I still find an impact on mortality rates, then it means that at least for this group, there is an increase in mortality without changes in population. Yeah, total population. Right, but I'm right. Yeah, right. Yeah, but it would have to be very much selected on health and very immediate. Yeah, fine.
Judit, can you tell me what's going on with the natives trend?
Population. Just people that. This is. What do you mean? Like why? Well, because a lot of people living, and then more fertility, I guess, also stops. I don't know. You know better. Yeah. So there's probably a lot of people left 2012. And also, yeah, I guess fertility. I mean, no, this is, yeah, and then fertility could also play a role here. Before, okay. So it's, yeah, so then it's people living. Okay, so when I use the predicted population as if the trend would have been the same for the native and for the immigrant, I still find a significant increase in mortality rates. And now what I'm gonna do here is I'm gonna regress the log of population, the number of individuals in logs, for each of the subgroups, okay? So for instance, for Africans, and I'm gonna be looking at whether the reform has any impact in the changes in population for each subgroups. So for example, for Africans, I do not find the reform having any impact on changes in population. And so there's no changes in population for this group, and I still do find an increase in mortality rate for Africans. Okay? Now, who are those that are living? Well, those that are living are individuals from Central and South America. Because for those nationalities, I do find that the reform induces a decrease in population in this subgroup of individuals. So then I cannot, I mean, I don't think this mortality rate can be interpreted because there could be selection in health. But for example, for Asians, there's also no impact of the reform on population changes. And again, I still find an impact on mortality rates. So the only way that I think I can solve this problem that you were mentioning is now I'm going to compute how big this change in mortality would have to be in order for my mortality effects to disappear. And I think I'm still, going to find impacts because I think these are strong mortality increases. But I will compute that. Yeah, I'm finishing. So at least for Asians and Africans, there's no change in population, and I do find increases in mortality rates. So this is where we are now. So we have 3 minutes to get your comments on how to proceed. So what we find is that restricting access to the healthcare system for undocumented migrants leads to strong increases in mortality, at least for some subgroups. And the impacts are stronger than the impacts that other papers estimate from extending coverage. So the reductions in mortality found for papers in the US of extending coverage are relatively smaller than the impacts that we find from restricting access. And we think this has important policy implications given the current trends both in migration flows and in restriction in access to the healthcare system for certain groups of the population. Thank you.